Okay, so I am talking today with Dr. Mark Hancock, who's in Australia. Hello, Mark.
Hi Rachel, how are you?
Good, thank you. Thank you for joining us today and having a little chat. We're going to be talking all about low back pain, hopefully, maybe some other things as well. But I can see that you're probably one of our most prolific researchers on low back pain in our profession, and we're really interested. I'm really interested to hear more about your work. But for the people that haven't met you before or come across you, I was wondering if you could just tell us a little bit about yourself and your work, so that we know what you get up to.
Sure. Okay, so I am a physiotherapist by background, trained at Sydney University, finished in 1988. So I've worked as a clinician pretty much since then. In the last year, I've done very little clinical work, but pretty much up until then, I've continued some clinical work and worked in America for a little while, mostly worked in a musculoskeletal setting and mostly in a primary care setting in Australia. I guess around about 15 years ago, I started doing a little bit of academic work, teaching. Then I did a research master's, originally in ankle pain. And then it was a slight switch in direction into low back pain in my PhD, which I finished in around about 2007. Yeah, so currently I work full time in an academic teaching and research kind of mixed role. And I've moved to a university called Macquarie University, been here about 3 or 4 years. And we've just built a new program here. So still within Sydney area.
Great, I didn't realise it was a new program at Macquarie. That's interesting. So is most of your research, has it been on low back pain, or do you do other things as well?
Yeah, no, almost completely low back pain. I've probably got 5 or 10% where I've done a few other things, and I guess a few studies looking at methodology type issues that don't just relate to back pain. But most of my research is definitely in back pain.
Great, that's great. So, right, we've got lots of questions for you then. um, so, I'm interested to know how have our views of low back pain and the research on low back pain, how has it moved on in sort of the past 10 years? What's happened in research and low back pain research in sort of the last 10 years?
Okay. Look, I think in some ways the biggest changes probably happened just a bit before that. So there was a shift from a kind of biomedical approach to back pain where we thought about particular structures, and then 15, maybe even 20 years ago, there was this gradual movement towards a kind of biopsychosocial approach to back pain. And I think research, probably more than clinical practice, has very much gone that way in the last at least 10 years or so. So the majority of the research, I'd argue, is looking at those elements of back pain, trying to better understand particularly the psychosocial, which I think is fantastic. But one of the things that will probably come out in our conversation today is that I'm a little bit of a believer that we've possibly gone too far in that direction, and that we haven't made the progress. I don't think almost anybody would argue that we haven't made the progress we'd like to in back pain. And I wonder if some of that is because we still don't really know enough about the actual causes of back pain. Now, that's very controversial. There'll be people who will listen to this, and lots of people who would argue strongly against that and say that would be a step backwards to go that way again. But when I've looked into that area in our research, for example, looking at some of the MRI work we've been doing recently, we actually still know almost nothing, and we actually really haven't done much of that work. So I guess that's a tension at the moment in research, in which direction we should go. And probably the other thing that's, I guess you could argue, changed more recently is as people have become aware of, I guess, the limitations of the non-specific approach to back pain that we've taken, where really, as you understand, we consider kind of 85 to 90% of people to have non-specific back pain without a specific cause. As we haven't had the good results in the trials that we would like to, there's pretty wide consensus that we need to subgroup back pain or stratify back pain. And it's really just a question of how we go about doing that. So I think, we've done a couple of surveys asking clinicians and researchers, what would be the number one priority in back pain research. over the last 5 years or so, and consistently that comes out as the number one. So I think most people agree with that. Then the question is, how do we do that? And that's one of the things we talked about at the World Congress of Physical Therapy, where we talked about some of the different approaches to doing that.
So talking about at the World Congress of Physiotherapy, it was the low back pain symposium on a stratified care approach to low back pain, wasn't it? That you you talked about the integration of all the different approaches that had been talked about in that symposium. So from that symposium, what do you think we can learn from the presentations that everyone gave, that the group of you came together and gave us this wonderful presentation? What do you think we can take away from that symposium, and perhaps even into our clinical practice?
Okay, sure. Well, that's a big question, a hard question. No, that's all right. What can we take away from it? Look, I think one of the positive things is that we're starting to make some progress in this area. A few people, including myself, have written how we need to be cautious as we look at subgrouping back pain, because it's difficult to do. It takes big studies to provide really good evidence. So as it's become popular, we've kind of jumped onto it in some ways without necessarily the evidence to support it. But we are, there are positive findings coming out. So Nadine and Jonathan, talked about the start back approach, and there's some really nice results coming out there. And Peter O'Sullivan talked about his classification approach, and again, some nice results. And both of those groups would argue that we need to validate those things and do more research in those areas. So I think one thing to take out of it is that we do have some more targeted approaches to back pain now, which seem to be looking positive. I think some of the challenges we all agree on, which are we need to work out when to use those different approaches, and I guess that's what I partly talked about there. So, which approaches are better for primary care, which approaches are better for chronic patients? Can we integrate the approaches? And I think genuinely we can, and I think for clinicians at the moment, based on some of the principles that I guess I talked about in that talk, and a little bit of common sense, I think you can start to work out when those approaches might be, best for your clinical practice and for different patients you'd see. So we'd like to do some research to actually show that, we can integrate these, and that certain ones do work better in certain settings. But, I think we've got the early evidence to support that.
Do you think we have all the models available to us that there could be? All the different classification and management models?
I think no is the short answer to that. And again, as I've already touched on, eventually I believe that a better understanding of the biology has to be a part of this. So you may or may not be aware of the research by Hanny Albert that caused a huge amount of interest a year or so ago. So Hanny and colleagues for a while have believed that maybe a modic change, which is something you see on an MRI, may represent an infection in the disc. And they ran a randomised controlled trial and gave those patients antibiotics, and another group got a placebo, and they had quite big effects. Now, a lot of controversy about that study, and no doubt it needs to be replicated, but there's 2 or 3 studies, I believe, at the moment that are going about replicating that. So I think there's no doubt that if we could understand that some patients have different sources of their pain, then that surely would form part of a stratified, kind of approach to back pain. But in addition to the other things, so 2 patients may well have the same source of their pain, but their psychosocial factors will still influence their outcomes, and the best treatment. So I guess I'm a big believer that we need all of those things together, and that's difficult to research, but that's not an excuse to kind of say we shouldn't look at it that way, because I think long term that's what we need.
Yeah, and I think in the symposium, in your presentation part of the symposium, you did a really nice job of bringing the 3 different models together that had been talked about, and so we'll include this with this discussion so people can have a look at it. But I think it really made sense, and I think it's quite exciting how we might be able to integrate these models together to provide a sort of wider stratification approach or model for us to manage people with low back pain. But I'm really interested in, and I know this is a point for discussion probably about, I know a lot of people are talking about moving away from the patho-anatomical sort of model of understanding, and you're talking about that perhaps we need to move back towards that model. And I know, some people talk about how we perhaps don't even need to learn anatomy or physiology anymore, but I suspect your answer to that question is that we probably still do need to be teaching that and learning that.
Oh, look, absolutely. But again, that's my belief. And I know people that believe strongly. To be honest, where I think the confusion comes is the distinction between current clinical practice and research. And I think this is where we get confused. So I would argue strongly at the moment that in day-to-day clinical practice, people should not be having MRIs. We've done lots of work along those lines, and we've published lots of things to suggest that. The difference is, I think, from a research perspective, we should be doing it to better understand. And I think, to me, they're very clearly different, what we should be doing in clinical practice and what we should do in research. But I think a lot of people struggle to differentiate the two. So because at the moment, there's not a good rationale for imaging people, for example, who've got acute, simple back pain, and there's good evidence that that's not required. Because of that, and because too much imaging does happen, people are very worried to start thinking about looking at imaging and causes of back pain, because I guess rightly they're worried that we'll kind of go back to that situation where too much imaging happens. But to me, they're separate issues. To me, we need a line of research and implementation that is about reducing current unnecessary imaging, etc. But we also need a line of research which helps us better understand back pain, because there's just very few conditions in the world that are so prevalent, so expensive, etc., that we know so little about. So it's fine for us as research to say we don't need to know about the cause of your back pain, but very few patients are kind of happy with that. And if you speak to people in the general community, they're quite astounded that we've kind of, you could argue, given up on finding a source of back pain. And again, the other thing that convinces me about this, as I've done more work recently, is we have strong opinions about these things, but we've really done almost nothing at looking at them. So just for example, we published a systematic review a year or so ago. Daniel Steffens was the author. And we looked at how many studies have taken a cohort of patients, performed imaging, and then followed them to see whether the imaging was predictive of what happens in the future. And, I think we found less than 10 studies total, and 2 or 3 were on people with back pain and 2 or 3 were on people without back pain, and they were generally small. So we just don't know the answer, is what I would say. So rather than people saying we know these things aren't important, I'd say we haven't investigated it properly and we should have a look.
So do you think if we start thinking again about causes of low back pain, is that going to change the way care approaches? Is that going to change the way we manage patients again? Or is that going to bring about new models of care or anything?
Sure. So I guess one of the challenges is, and when we try to get research funding to do this, a common question is, well, what will, if tomorrow that somebody's pain is from the disc and somebody's from the facet joint, how will that influence treatment? And right at the moment, not obviously, but I think Hanny's work is a good example of, when we start to understand these things properly, then potentially there's a new treatment we never even thought about. You look at stomach ulcers, and as people actually understood what the cause of them was, the treatment changed radically. And, there's hundreds of examples of that in healthcare. So I think just because we don't automatically know the treatment now, if we can start to clearly identify the source of patients' pain, then we can start trying targeted treatments in those groups of patients who are more similar, potentially. Maybe that's the current treatments we've got. So maybe manual therapies and stuff will work better in certain groups of patients based on a pathoanatomical understanding. But maybe we'll also develop other interventions or new interventions. And I think that's completely realistic, really. It may not in a couple of years' time, but otherwise I think in 50 years' time we'll be doing pretty much what we're doing now.
And I guess it may just be that we incorporate our new understanding into the models that are already existing, so we have a better understanding of those models.
Completely. And I mean, for example, one of the things I'm most passionate about is we have really good evidence that there's a big group of patients who recover really nicely with minimal care. I mean, people report different statistics on this, but we've done a couple of big trials. One recently with 1,600 people in a randomized trial, and followed those people very, very carefully for 3 months. And about 85 to 90% of those patients had recovered within 3 months, and a big proportion had recovered within a couple of weeks. So, we don't need complex interventions for this group of patients. And, when we talk about integrating different models or different stratified care approaches, approaches like the Start Back tool, and I think those approaches will improve in the future, which really say, look, this patient in front of you has a very good prognosis. Their chance of recovering with minimal intervention is really high, within a short time frame. Those, we should be, that's critical information. I think that's probably where we've made the most progress in the last, 5 or 10 years in lots of ways, is better understanding that, even though we don't fully understand it. So that information will always be useful, but as you said, it's adding this other information in patients who don't recover, etc. And maybe the patients who have different prognoses, I would imagine that the pathology may be a part of that. Their psychosocial things will be a part of that. But common sense would say that, some type of injuries, if we think about the cause of injury, might heal more quickly and others might not, So again, it's only going to be one element, and I want to be really clear about that. It's only one element of the true biopsychosocial model, that I believe in strongly.
So still really important for us to learn all of our anatomy and physiology so that we have that basic understanding to be able to take that forward as we do into the care of our patients.
Look, absolutely, I would say absolutely, yeah.
Yeah. Okay, that's really interesting. So what I wonder now is, what do you think is the most powerful piece of knowledge that a physiotherapist can have when they're treating someone with low back pain? So, when I'm in the clinic and I have a patient coming in with low back pain, what should I be thinking as that patient walks in the door?
Geez, I don't know if I can tell you one most important piece of information. I'll tell you a couple that jump to mind. Yeah, sounds good. Look, we still, I think in most parts of the world where we're acting as primary care practitioners, but even if we're not, we still have this role to identify the very small group of patients who have a serious pathology. And that's critical. So, patients who have a cancer or fracture as the cause of their pain. And again, the group that I work with in Sydney and at the George Institute have published some really nice work on that. So we know that there's really almost no red flag on its own that's very powerful in predicting that. But when we have clusters of findings, then they are. So, if a patient is an older lady, who's had a trauma and she has a history of steroid use, then, fracture becomes really very, very likely. But if she only has one of those characteristics, then it's not. So I think an understanding of red flags and how to use them appropriately, so that we do identify likely serious pathology, but we also minimise the number of patients that we're just sending off, for further investigations, because we know they're actually very, very rare. So probably, 1 or 2 in 1,000 in a primary care setting. So it's rare, but we need to do it. Then I think incredibly important, that's right. And that's why, whilst it's so rare, we spend a lot of time in our teaching programs, talking about it. So that's critical. Then I think this idea of prognosis is critical, being able to look at a patient in front of you and think, is this person likely to do very well, regardless of what I do, over a short period of time? And that doesn't mean we don't have an important role. In our trials where we found people do well with minimal care, they're often still seen 2 or 3 times. I think the guys with the Start Back approach emphasise this as well, that it's an important role in kind of still monitoring people, and it's minimal care, but it's not no care. It's still good advice. And, that advice is probably one of the most, powerful tools that we have as treatment. So when you say, well, what are the most important skills or most important things to do, I think being able to deliver good advice that we kind of think that's really simple, but it's actually not, to really engage your patient with that to get them to really understand why that makes sense, rather than just giving them things to go home and do, but kind of explaining that. So if somebody's got pain and you just tell them, look, you need to kind of keep working and keep doing everything, if they don't buy that model, then they're not going to do it, even if it is the right thing. And again, I'd argue that's where, for example, Peter O'Sullivan's approach is great, because they really give people a model for cognitively understanding their pain. So again, it's that drawing from different approaches. But I think giving people a good understanding within our current knowledge of their symptoms, and that's actually quite hard when you're trying to tell somebody they've got non-specific back pain. You can't use those words, to a patient. That's terrible. So how do you explain that so to the patient it actually, they trust you, and it sounds like you know what you're talking about, and they're willing to go away and, do whatever you ask them to do. So I think that's critical, good advice. There's some trials at the moment, really looking at just that element of care and, even explaining pain and people's understanding of pain. We haven't talked much about understanding pain today, and that's a critical area that there's been a huge amount of research in recently. A good understanding of pain physiology and being able to, again, explain to patients, why their anxiety or fear of movement and things like that can actually exacerbate their pain. And again, very difficult to say that in a way that is appropriate and truthful and helpful to a patient, rather than them just hearing the message that you're telling them that it's all in their head. Do you know what I mean? So these are really difficult skills. So delivering that simple care that we often talk about is not so simple, I would argue, to deliver. So I think you need those skills. And then I think in chronic back pain, there's no doubt that most of the evidence is about active treatments involving exercise. And I think you need to be good at delivering, exercise for back pain, and have a few approaches. There's lots, as but at least be confident and competent in the most common ones, and I guess the most evidence-based ones, so that you can apply that to different patients. That's a long answer to one.
Yeah, and it brings up lots of questions in my head, which I've forgotten several of them now. But I think one of the things that, from listening to you talk, I think we tend to forget how knowledgeable we are, and how giving the simple advice to patients is something that they just don't think about on their own. And we can just give the simple advice of, just a few really simple exercises and a simple explanation. And we think that's not very valuable, and we think we have to do much, much more in our treatments because we feel like we need to give people value. But actually that simple advice is probably, like you say, one of the most valuable things you can do. But we don't feel that it's valuable because we have so much more to give. But so I think we need to, from listening to you, it's really important that we don't overcomplicate some of our treatments as well in the management of our patients.
Absolutely. This is something I'm really passionate about, and not just in back pain, but in everything. As physio, in every country, the setting in which we work is different, the way we get paid, etc., is different, and that influences some of this. But, in Australia, it's primary care practitioner most of the time, and I keep emphasising to our students that, if you go and see the doctor, you don't always expect to walk away with a treatment or a fix. You want to know what's wrong with you, and you want to know what to do, and you can feel very, very happy with that consultation based on that. And I think that's the next step for us as physios in a lot of ways, is to really value that knowledge we have, and value that when we pass that knowledge on and give people a diagnosis, even if it's a kind of non-specific diagnosis, give them good, interventions they can do themselves, or self-care, that's a really important, good intervention. And I think, exactly, it's often we who don't value that more so than our patients, So we've actually been asking some consecutive patients in clinical practice exactly these questions recently. So asking them about, why are they turning up? Do they actually always expect a treatment for their pain, or are they turning up for information about, to be, told that there is nothing serious wrong with them, and just have that confirmed, and to be told that would they be happy if they just get prognostic information, etc. I think most of our patients are telling us they see all of those things as really important. They're not just turning up, to have their pain treated. Every patient's different, but it's critical.
Yeah, obviously there are some who want the most complicated treatment and the most value for their money, but maybe we have to reduce their expectations in some way, or manage them. So the other thing you talked about was pain, and yes, we need to have a good understanding of pain, especially in low back pain, especially when we're talking about non-specific low back pain that we don't know the cause of, and all that sort of thing. So, with regards to low back pain, what is the thing that physiotherapists should try and have the best understanding of? Sort of, if a physiotherapist, having listened to this, wants to go away and find out more about pain in relation to low back pain, what should they be reading, looking up, trying to understand?
Sure. Look, there's lots of good websites and resources for kind of a basic understanding of pain physiology these days. And so I think people should understand that, and particularly the issues related to chronic pain. And what are the things that can exacerbate? So really the changes in the nervous system that can, I guess, heighten people's pain and arguably even produce pain, independent of a nociceptive source. So I think it's critical that people understand that, but again, more so that they know in some ways how to talk to their patients about that, and that's critical. So, Lorimer Moseley and, his colleagues and stuff talk a lot about explain pain and these kind of ideas. So I think for people that don't know about that, though more and more I think most people do, there's hard to find a conference where there's not people talking about pain. Some people, and this is where you get into, just at the moment, different people's favourite approach or what people believe in. And some people would argue that's it, and if we get that right, that'll be the answer. But I still think in most cases there's a nociceptive source of pain. I don't really buy the idea that it always just goes away in 6 weeks. So if you have pain after 6 weeks, there's nothing wrong. I don't agree with that. So I think definitely what's going on with your nervous system will change your experience of pain, and it's a powerful treatment and it's something we need to know about, but I don't think it's everything. Yeah. And there's nice research coming out showing that in other conditions like the hip, when the nociceptive source of pain is treated, for want of a better word, somebody has a hip replacement, etc., that actually some of the central changes revert. So that idea that those central changes are irreversible, I think is becoming pretty clear that's not the case. So if we can treat people's pain centrally, that's great. But if we can treat it peripherally as well, I think that's also good.
Yeah, definitely. So one of the one aspect of low back pain is the one huge topic that I'm reluctant to delve into, but I've started the question now, is acute low back pain moving into chronic low back pain. If we think about the sort of models of care that have been presented in your symposium and things, what sort of techniques should people be using or thinking about to try and manage this, to prevent the move from acute low back pain into chronic low back pain for a patient?
Sure. That's tricky.
Yeah, I'm not sure I asked that question very well.
No, I think I understand where you're going, and I think there's a few parts to that, because often studies are set up as preventing people, progressing to chronic back pain. But in other way, you could also just interpret that treating acute back pain, etc. It gets a little bit complicated. So in some ways it covers some of the issues we've already talked about. So I think not over-treating people, as long as there's a pretty good sense that those patients will do well. But the start back approach is a pretty good example of this, really, where you're identifying a group of patients who you think have a good prognosis, you're giving them minimal treatment, and it doesn't really seem that if we treat them a whole lot more that we get better outcomes. But in the people who early on can be identified at greater risk of developing chronic back pain, which is really what the START tool's about, then in those patients, if we give them more but still good treatment, not just more bad treatment, give them more appropriate treatment, then we do seem to help some of those patients hopefully not go on to get chronic back pain. But again, the reality is we're not as successful at that as we'd like to be at the moment. I mean, that is the plain reality, so, but that doesn't, I guess the risk, well, there's risks on both sides, but the risk there is thinking, well, because it's so important we stop people getting chronic back pain, let's just treat everybody a lot, do you know what I mean, and try everything to stop them becoming chronic. But it really is a small group of patients who are going to become chronic, and as I said, too much intervention, too much imaging, things like that, have the, and not, we always talk about imaging being a bad thing as physios, but, more and more good physios who I talk to agree that the things we can do as physios can actually lead, be part of the problem, not just the solution. Some of the motor control stuff, which I think is very appropriate for some patients. I've seen patients become completely confused and obsessed about what their muscles are doing to a degree that is definitely harmful for them. So it's kind of like we were saying before. There's a lot of skill in picking the right person, but also delivering those therapies appropriately in a simple way, so we don't actually cause harm, which we can do. It's too easy to just think, it's medicines and surgery and things that can cause harm. I think we can cause harm.
Yeah, I think that's a really good point. And it seems like it might be the best skill you can have to prevent progression to chronic back pain is by identifying those patients at risk in the first place. So that's your first point of call, really. And if we can become skilled at that, then we can manage them appropriately and try and make a difference. And then I suppose as our physiotherapy model for managing low back pain improves or becomes more developed, or is, we work on it more, then I imagine that's going to give us a better skill to then apply to those patients that we've classified whether they're at risk or not in the first place.
Yeah, look, absolutely. And that's, again, back to the WCPT talk. That was kind of the model we were, talking about towards the end. So, really joining those approaches together and having approaches to identify the simple patients who don't need much, to try to avoid the development of chronic pain in the patients who do look at risk, and then having good treatment. The idea that someone's had chronic back pain and they can never get better is, again, not evidence-based. Lots of those patients do very well. And having good treatments, for those patients that need it, that do go on to develop chronic back pain.
Yeah, I think from talking to you today, it sounds like, we as a profession and with all the research that's been done, we've come a long way. We've come an awful long way, and we have some models of care to apply, and we have an understanding of what we should and shouldn't be doing. We've also got a way to go to develop those models. But I think it's been really useful to talk to you today just about the different aspects of low back pain, and we've brought pain into it. I wasn't expecting to do that, but that's really nice. Do you have any other pearls of information, or clinical pearls, or good pieces of information that you'd like to just hand out to everyone today, or do you think we've covered everything about low back pain? Or it could not be about low back pain if you'd like to have something else.
Not really. No, look, I think we've covered the main issues. I think there's quite a few promising, approaches coming out. We ran a trial recently where we had 2 exercise approaches and they had exactly the same outcomes, which is disappointing, but what often happens. But then we did a secondary study where we selected the patients kind of based on a tool that's in a very early stage of development, but for patients who seem to have more of a kind of motor control problem or a clinical instability. And the trial was looking at motor control versus kind of a more general or graded activity approach. And we found that the patients who, had, according to this scale, more subjective instability did much better with the motor control approach, and the patients who didn't did much better with the graded activity. And that's exactly what we've been searching for a long time. And as clinicians, we think that's what happens. We're quite confident that we can pick the right patients. But up until now, we've struggled from a research perspective to kind of, demonstrate that. So again, trials like that, we need to replicate, etc. And we always know that's important with those kind of studies. But yeah, so I think there's some good news out there. But I don't think there's one kind of, pearl of wisdom or, answer to back pain. I think we realise that more and more. I think the best clinicians have quite a few approaches in their tool bag. So maybe my bit of advice would be, don't just be a believer in one thing. I think you might be very interested in pain science, and that's fantastic, but it's good to be really good at other things and to understand the other approaches we've talked about today, etc. And I think the best clinicians are going to be the people that can pull all those things together.
I think that's very wise words indeed. And so thank you very much, respectful of your time. I won't keep you for too long, but I just want to say as well, thank you for all the research that you do, because without the research that you guys are doing, you know, we wouldn't be moving on like this and having this better understanding. So it's really good to have you out there doing that sort of thing. So thank you.
No problems.
All right, well, thanks for talking to us today. It's been really, really good. I hope everybody enjoys it, and maybe we'll talk to you again in 10 years' time. It'll be a completely different conversation.
Sounds good. Thank you.
All right, thank you.